Welcome to our video on compartment syndrome. Let's get started. In this lecture, here's an overview slide of the information we'll be discussing with regards to compartment syndrome. Let's begin by reviewing the definition. Compartment syndrome is when the pressure of one or more anatomic compartments increases to the point where tissue perfusion is either decreased significantly or stopped altogether. We'll discuss this in regards to the upper and lower extremities. Let's go over the pathophysiology of how compartment syndrome occurs. Here we have the heart and arteries that take blood to the rest of the tissues, as well as a capillary network where gas exchange occurs. Next, we have the venous system, which takes blood back to the heart. Now, if the pressure within the tissue compartment increases to the point that it overcomes the pressure in the veins will collapse and venous outflow will decrease. This will increase hydrostatic pressure within the vessels, decrease inflow of arterial blood, and result in transitation of fluid from the capillaries into the soft tissue space. The final key element is the fascia surrounding the anatomic compartment. This is a rigid structure that will not expand with the expanding pressure, which leads to increased pressure in the compartment and a positive feedback loop that compromises the supply of oxygenated blood from the arteries and outflow of deoxygenated blood from veins. The end result is hypoxia, which can induce tissue necrosis. We'll discuss what can trigger this cycle in the risk factors section. This is a gross depiction of the swelling of the anatomic compartments. For completeness sake, we'll add some peripheral nerves here in purple, like this. Because there is swelling in the tissues, the nerves may get compressed, leading to the clinical features of paresthesias and paralysis, which we'll discuss in more detail later. All right, now let's move on to discuss risk factors. The risk factors for compartment syndrome are directly related to what can cause the increased capillary leaking into the soft tissue compartments. This would include patients with multiple traumatic injuries who undergo large volume resuscitation. Circumferential burns are on this list due to the eschar formation after the burn, which reduces the size of the compartment in addition to the increased capillary leak. Fractures and prolonged surgery or immobilization are also risk factors due to the local inflammation, capillary leak, and compartment edema. Increased perfusion pressures induced by reperfusion of an ischemic tissue and tissue edema with increased capillary permeability after snake bites are other important causes of compartment syndrome. All right, let's try a question. Why would a patient complain of numbness between toes 1 and 2 be a concerning finding suggesting possible compartment syndrome? All right, to answer this question, we need to think back to cutaneous nerve distributions. As seen here, the cutaneous innervation for the first web space is the deep peroneal nerve. Now, the deep peroneal nerve courses through the anterior compartment of the lower leg. If the anterior compartment is experiencing increasing pressures, which can be seen in compartment syndrome, the deep peroneal nerve might become ischemic. The involvement of the deep peroneal nerve is the most plausible explanation for the sensory alterations of this patient. For acute compartment syndrome of the extremities, the clinical features are pain, especially with passive range of motion, as well as paresthesia, which is one of the early findings, and paralysis, which is rare. Pallor and poikilothermia are some of the other common features. For your reference, poikilothermia means cold extremities. The tissue will also feel tense from all of the extra pressure in the compartment. All right, let's try another question. What are some of the clinical features that help differentiate acute arterial occlusion from compartment syndrome? There's a lot of overlap between acute arterial occlusion and compartment syndrome of the extremities. For example, both can present with the 6 Ps, which are pallor, pain, paresthesia, paralysis, pulselessness, and poikilothermia. However, pulselessness is more common in acute arterial occlusion. On the other hand, a key feature of compartment syndrome that is generally not found within acute arterial occlusion is the pain that occurs with passive range of motion. To reinforce the clinical features of compartment syndrome and contrast it with those of acute arterial occlusion, we'll use this foot. Overlapping symptoms of the two conditions are cold, paralysis, and discoloration. We would not expect to see pulselessness in compartment syndrome, though we would expect to see it in acute arterial occlusion. This is because the pressure in the compartment is altering capillary flow, but is not high enough to stop the arterial flow. Now, compartment syndrome can progress to the point where pulses are absent, but it's a poor prognostic indicator. Also, one of the key features of compartment syndrome is that whenever a movement is produced by some external force, the patient feels pain. In other words, there is pain on passive motion. For patients with the classic history and physical exam of acute compartment syndrome, the diagnosis is made clinically, and measurement of the compartment pressures are contraindicated. This is because it's such a serious diagnosis and may lead to false negative results. If the suspicion for compartment syndrome is low, then it might be obtained for confirmatory documentation. Or in cases of altered mental status with a lack of reliable history or physical exam. The calculation of this pressure is the delta pressure, which is the diastolic pressure minus measured intracompartmental pressure. If the difference is less than 30 millimeters of mercury, it's strongly suggestive of the diagnosis of compartment syndrome. All right, now let's move on to discuss treatment. The initial treatment would be to remove any external physical constraints, such as bandages and casts. The definitive treatment is decompressive fasciotomy of all anatomic compartments of the affected limb. All anatomic compartments of the affected limb must be decompressed because it's difficult to reliably rule out compartment syndrome in adjacent compartments. Delay in diagnosis and treatment can result in multiple complications. Ischemia and tissue necrosis can result in loss of limb. Hyperkalemia may develop due to the increased release of intracellular potassium from dying cells, and acidosis can result from excessive lactic acid production induced by hypoperfusion of tissues. Release of myoglobin and uric acid from dying myocytes can result in renal failure, as these substrates are toxic to tubular cells. Finally, Volkmann's contracture can result from prolonged ischemia of the forearm muscles, which results in the permanent shortening of these muscles. Volkmann's contracture is classically seen in children who have sustained a supracondylar fracture and compartment syndrome of the forearm. The eventual result is a claw-like hand with flexion of the wrist and insensate nerves. All right, let's wrap up with a question. A 17-year-old male fractures his tibia in a motorcycle accident. After the accident, he complained of extreme pain and decreased sensation. His right lower extremity had taut skin and was pale compared to the left. The patient received appropriate treatment and is now presenting for his follow-up appointment 4 weeks later. On physical exam, the physician notes that the patient has decreased sensation along the lateral aspect of his right leg and is not lifting his right foot when he walks. The physician informs the patient a nerve was likely damaged during the procedure, resulting in his symptoms. What is the most likely nerve? A. Sural nerve, B. Saphenous nerve, C. Deep peroneal nerve, D. Superficial peroneal nerve, or E. Common peroneal nerve. All right, this patient had a fracture in his lower extremity, followed by the clinical features of compartment syndrome, namely extreme pain, paresthesias, tense skin, and pallor. His clinical presentation was enough to make the diagnosis and proceed to perform fasciotomy. He now has findings consistent with a superficial peroneal nerve injury. This is supported by the decreased sensation along the lateral aspect of his right leg and not lifting the foot when he walks. The superficial peroneal nerve, as the name implies, passes superficially in the lateral compartment of the lower leg. It's therefore easily damaged during a fasciotomy. So this makes D the correct answer. All right, let's pull up a picture to discuss the incorrect answers. From this image, we can see that the sural nerve is responsible for cutaneous sensation of the posterior lower leg. So A is incorrect. The saphenous nerve innervates the medial skin of the lower leg. So B is incorrect. The deep peroneal nerve can be compromised in anterior compartment syndrome, but damage is unlikely with a fasciotomy because it runs deep. Furthermore, the patient would develop sensory alterations in the first web space. So C is incorrect. The common peroneal nerve branches into the superficial and deep peroneal nerves, and damage to this nerve could result in the patient's symptoms. However, it's less likely to be damaged as part of a fasciotomy because of its deeper course, and signs of a deep peroneal nerve injury would also be present. So E is incorrect. And again, the correct answer is the superficial peroneal nerve. And that concludes this section.